Now, insulin. Let's talk about insulin, its history and chemistry. Insula means island, and insulin is the first protein proved to have a hormone action. The chemistry is that it is a small protein with molecular weight 5808. It contains 51 amino acids arranged in two chains. The changes in the amino acid in both chains are the species differences. This is a picture showing the molecular formula or molecular the structure of insulin. Different amino acids are seen. Now, synthesis. Insulin is synthesized as preproinsulin and then becomes proinsulin and then hydrolyzed into C-peptide and insulin, which is 51 amino acid protein, and the 4 amino acids are cleaved off to circulation. Now, storage. It is stored within the granules of the beta cells of the pancreas with insulin and C-peptide. It is stored in the form of the crystal, and the entire human pancreas contains 8 mg of insulin. Now, species of insulin. Human insulin, bovine insulin, porcine insulin, recombinant DNA technology with entheogenicity, the bovine, porcine and human. Now, release of insulin. Insulin released from the pancreatic beta cells, and the glucose enters into B cells and mediated to ATP, and there is increased ATP level which closes ATP sensitive potassium channel, thereby decreasing the outflow of the potassium efflux and depolarization of the B cells and opening of the voltage gated calcium channel, which causes intracellular calcium, which releases insulin. Now, the factors influencing increased insulin secretion. Glucose is the principal factor. Mannose and fructose, amino acid like leucine and arginine, vagal activity, intestinal hormones like GIP, GLP-1, gastrin, cholecystokinin, secretin, BIP, enteroglucagon, and drugs like sulfonylureas. Now, pharmacokinetics. When given orally, it is degraded by the proteolytic enzymes because insulin is protein in nature. So, it is given parenterally, usually by subcutaneous method. It is not bound to plasma protein and the circulates free in blood as monomer, and the serum half-life is 3 to 5 minutes. It is metabolized by two main organs, liver and kidney. The endogenous insulin by kidney 40% and liver 60%, and exogenous insulin by kidney 60% and liver 40%. The insulin degraded by insulinase to degraded products, and then these are again metabolized by proteolytic enzymes. The insulinase by glutathione insulin trans dehydrogenase. Now, this is a picture showing different organs acting with relation to the insulin. Now, mechanism of action of insulin. The insulin binds to alpha subunit of the insulin receptor present in the cell membrane, and it causes confrontational changes and causes phosphorylation and autophosphorylation of the tyrosine kinase of the cytoplasmic beta subunit, and it is the first protein to be phosphorylated. And there is insulin receptor 1 and insulin receptor 6 phosphorylated tyrosine kinase. These are the substrate providing docking site for the other signaling protein, and first activates phosphatidyl inositol 3 kinase and then activates GTP binding, leading to protein RAS complex and MAP kinase. The translocation of the glucose transporter causes increase in the glucose uptake, increased glyconeogenesis, increased glycolysis, reduced glycogenolysis, reduced neoglucogenesis, so reduced blood glucose level, increased lipogenesis, reduced lipolysis, increased protein synthesis, increased cell growth, and others. The factors increasing the number and affinity is insulin receptor, starvation, excess growth hormone exposure to reduce insulin. Factors reducing the number of the insulin receptor, obesity and excess glucocorticoid. Now, pharmacological effects. It is a anabolic hormone which controls intermediary metabolism. The effects are traditionally classified into 3 based on their kinetics. First, immediate effects are rapid effects. Phosphorylation and dephosphorylation of the enzymes leading to increased transport of the glucose and amino acid and activation of the ion transport system. The intermediate effects includes activation of the glycogen synthase and glycolytic enzymes, inhibition of the phosphorylase and gluconeogenic enzymes, stimulation of the protein synthesis, and inhibition of the protein degradation. The delayed or long-term effects includes increased mRNA for lipogenic and other enzymes and stimulation of the cell proliferation and differentiation. Effects on liver includes increased hepatic glycolysis, reduced glycogenolysis and gluconeogenesis, increased glucose uptake, glycogenolysis and reduced ketogenesis, increased TG synthesis, increase BLDL, reduce CAMP, and increase uptake of the potassium by liver. On muscle, increase amino acid transport, increase protein synthesis, increase ribosomal protein synthesis, increase glucose transport, increase glycogen synthesis, and increase glycogenesis. There is induction of the glycogen synthesis in the inhibition of the phosphorylase. Now, effects on adipose tissue. It activates hormone-sensitive lipoprotein lipids and hydrolyzes lipoproteins to triglyceride. It inhibits lipoprotein lipase and causes increase in the TG synthesis, reduce free fatty acid, increase triglyceride storage into the adipocyte, and reduce lipolytic action. Effects on the glucose transporter. Glucose transporter 1, 2, 3, 4, 5 are stored within the intercellular storage vesicles in cytoplasm. When insulin combined with the insulin receptor, GLUT is inserted into the cell membrane and glucose is entered into the cell by small or simple diffusion. Now, effects on carbohydrate metabolism. Increased glucose uptake, glycogenolysis, glycolysis, glycerosynthesis, and reduced gluconeogenesis. On protein metabolism, reduced protein metabolism and increased amino acid uptake and protein synthesis. On fat metabolism, increased lipogenesis, increased free fatty acid synthesis, triglyceride synthesis, and reduced lipolysis. Now, relation to potassium and calcium. Insulin causes increased potassium entry into the cell by sodium-potassium ATPase and reduces extracellular potassium, leading to hypokalemia. Insulin increases the uptake of the calcium into cell, so hypercalcemia causes increase in the insulin. Effects on cell proliferation. It stimulates cell proliferation and so helps in the somatic growth, cellular growth, and development. Now, these are the different preparations of the insulin with their onset and duration and the drugs. Very short acting is insulin lispro, insulin aspart, insulin glucosilin, and inhaled insulin. Short acting includes regular or soluble crystalline zinc insulin. Intermediate acting includes neutral potamine hexadrone or isophene insulin. Long acting includes ultralente insulin glargine and insulin detemir. Mixture of the insulin may be neutral potamine hexadrone and regular, neutral potamine lispro and insulin prispro, and neutral potamine lispro and insulin aspart. All insulin are available in the strength of the 100 units per milliliter and available in premixed formulation. Insulin delivery system. It may be portable pen injectors, continuous subcutaneous infusion, insulin infusion devices, and inhalation of the insulin. Clinical uses includes type 1 diabetes mellitus, juvenile diabetes, diabetic ketoacidosis, diabetes with pregnancy, type 2 diabetes with complications, failure of the oral hypoglycemic agents in type 2 diabetes, and emergency treatment of the hyperkalemia. Now, adverse effects includes hypoglycemia or hypoglycemic shock, which is the most common effect. It may be due to delay in the taking meal or less carbohydrate intake or more insulin intake or unusual physical exercise. Symptoms include tachycardia, palpitations, sweating, tremulousness, nausea, hungry, may progress to confusion, convulsion, and unconsciousness. The treatment is, if patient is conscious, prompt intake of the oral carbohydrate, oral juice, dextrose tab, glucose gel, or any sugar-containing beverage. If unconscious, 50% glucose, IV infusion should be given over 2 to 3 minutes, and injection glucagon 1 mg subcutaneous or intramuscular should be given, and injection adrenaline should be given. If insulin allergy is seen, then type 1 hypersensitivity is rare, and the type 2, 3, 4 develops with the non-insulin protein contaminants. Insulin resistance is very rare and said to be resistant when insulin intake more than 200 units and produces no effects. The most patients develop low titer of the IgG antibody. Lipodystrophy at injection site may be seen. Weight gain is a common side effect, and hypokalemia may be seen.